Hello, and a very warm welcome to this clinical pharmacology and therapeutics podcast on antilipid agents. During this podcast, I'm going to use the context of hyperlipidemia and the primary and second prevention of vascular disease to discuss the most important classes and examples of antilipid agents. As usual, I'm going to consider the most important indications for the drugs under discussion, and then for each class of drug, talk about specific drug examples, mechanisms of action, and importantly, each class's adverse profile. So first, let's introduce the topic by discussing the most important indications for deploying this particular group of drugs. Predictably, the first of these is hyperlipidemia. By hyperlipidemia, we of course mean elevation in blood lipids such that the benefit of treatment outweighs the risk. Of course, elevation in blood lipids may be either hereditary or acquired, and the hereditary causes are summed up in the Fredrickson classification. This encompasses type 1 through 5 hyperlipidemias depending on the primary lipid particle elevated, the appearance of blood serum left overnight, and specific associated disorders. Detailed discussion of this classification is unfortunately beyond the scope of this podcast, but you should certainly know of its existence. Important acquired causes of hyperlipidemia include hypothyroidism, nephrotic syndrome, diabetes mellitus, and a variety of medications, the most important examples of which are steroids, alcohol, thiazide diuretics, and the oral contraceptive pill. Leaving hyperlipidemia aside, there are a few other very important indications for starting antilipid therapy, namely in the setting of primary prevention with a calculated risk of cardiovascular disease greater than 20% over 10 years. In addition, they are indicated in the setting of secondary prevention, where there is clinical evidence of cardiovascular disease, for example following a cerebrovascular ischemic event such as stroke or TIA. Also with known or suspected ischemic heart disease, and also with peripheral vascular disease. Lastly, antilipid agents are often started for patients with type 1 or type 2 diabetes, who have either very poor control or complications, either micro or macrovascular complications. Before moving on to the most important drugs that are used in the management of hyperlipidemia, let's briefly mention important non-drug or conservative measures. These include a low-fat diet, although I think it would be fair to say that success with this is quite rare, reducing alcohol intake, as if you remember, this is an important secondary cause of hyperlipidemia, and of course promoting a healthy lifestyle by advising your patient not to smoke and through increasing levels of physical exercise. For a more extensive discussion of all the indications and the settings for the use of antilipid agents, have a look at the May 2008 National Institute of Clinical Excellence guidelines. These can be found in various forms at www.nice.org.uk. So in the next section of this podcast, we're going to look at specific classes of antilipid drugs. The statins will probably be the drugs with which you are most familiar, and I'm sure you will have encountered many patients on the wards or in clinics who are on these agents. There are of course many specific statins available, but the three you should probably try and remember are simvastatin, rosuvastatin, and pravastatin. The principal mechanism of action of this class of drug is to inhibit the rate-limiting step of hepatic cholesterol synthesis, namely the enzyme HMG-CoA reductase. This reduces circulating cholesterol levels by two principal actions. Primarily, there is a reduction in hepatic cholesterol output that accounts for approximately 50% of circulating blood cholesterol. Secondarily, there is an increase in LDL receptor synthesis, and this increases liver uptake of circulating cholesterol and thus reduces total plasma cholesterol. Like all the agents that we're going to discuss, statins have more effect on certain lipid classes. Namely, statins reduce plasma LDL, sometimes by much as 40%, and increase plasma HDL. Although they do work as well by reducing serum triglyceride concentrations, this effect is less pronounced. With regard to the key clinical pharmacology, statins are the usual agents that are used first line in both hyperlipidemia and the primary and secondary prevention of vascular disease, but other agents may need to be considered if hyperlipidemia is dominated by triglycerides or are poorly tolerated. The introduction of other agents apart from statins is usually performed in the specialist setting. Note that these drugs are usually given at night, as for some unknown reason they tend to have a greater action over that period. Statins are usually well tolerated, but the most important side effects that you definitely need to be aware of are hepatotoxicity and myositis. Hepatotoxicity secondary to statin therapy is characterized by an elevation in the transaminases, namely ALT and AST, and for this reason LFT should be carried out on all patients before starting statins and then after 3 months. If the transaminases show a rise or a sustained rise of 3 times the upper limit, then they should be discontinued. Myositis is a rare but important complication of statin therapy that involves muscle pain that is usually proximal, together with a rise in plasma creatinine kinase or CK, representing leakage of this enzyme out of the muscles. If prolonged or severe enough, myositis may involve the kidneys, in which case it is referred to as rhabdomyolysis. The next class of drugs that we shall consider is the fibrates, important examples of which are fenofibrate, bezafibrate, and gemfibrozil. These drugs are overall less effective than the statins at lowering cholesterol, but better at lowering triglycerides and increasing HDL cholesterol. They work by activating the PPAR alpha receptor that is heavily involved in lipid metabolism. This occurs through a number of mediators, including ApoA1, C3, and lipoprotein lipase. Activation of these mediators results in reduced hepatic production of cholesterol and increased peripheral clearance. Fibrates are not commonly used, but may be initiated in a specialist setting in patients for whom the combination of intensive lifestyle management and a high dose of statins has been unsuccessful. They can also be used for patients who do not tolerate statins. Importantly, these drugs should not be used in any patient with severe liver or kidney disease. Important side effects are just like the statins, myositis and hepatitis, and in fact, if used together with the statins, the fibrates increase the risk of these complications developing. They also, by increasing biliary cholesterol excretion, increase the risk of gallstone formation. Next, we shall talk about anion exchange resins, the most important example of which is cholestyramine. This drug cholestyramine works by acting as a sequestrant of bile acid in the gut, thus reducing absorption of cholesterol. It has also been shown to upregulate LDL receptors, thus increasing cholesterol clearance. The predominant effect of this agent is on LDL cholesterol, and sometimes up to a 30% reduction is seen. Anion exchange resins are, just like many other non-statins, indicated for patients who cannot tolerate statins. Important adverse effects include GI disturbance, characterized by bloating, nausea, and sometimes constipation, and also they may paradoxically exacerbate hypertriglyceridemia. Ezetimibe is a new type of lipid-lowering agent that functions as a cholesterol absorption inhibitor. Importantly, however, unlike the bile acid sequestrants which we just mentioned, it does not increase bile acid secretion, and therefore does not predispose to gallstone formation. It also has no effect on cytochrome P450, so is much safer to take with other medications. Ezetimibe sets itself aside from the other non-statin antilipid agents in that it may be used in primary prevention, specifically for the treatment of heterozygous familial hypercholesterolemia. Otherwise, it is sometimes used in combination if monotherapy with statins is unsuccessful. Side effects are rare and mild and include GI disturbance and sometimes headaches. Finally, we shall just briefly mention nicotinic acid. This drug works by reducing the mobilization of fatty acid from adipocytes, and thus has a positive effect on all classes of cholesterol. Unfortunately, nicotinic acid is poorly tolerated due to a variety of prostaglandin-mediated symptoms, important examples of which include flushing, nausea and vomiting, and dyspepsia. A modified release preparation is available that reduces some of these side effects. Nicotinic acid, like most of the other drugs we've talked about, is initiated in the specialist setting, particularly for patients who are unresponsive to normal therapies. So that just about completes this podcast on antilipids. In this podcast, we've discussed important indications for the initiation of antilipid therapy, namely hereditary and acquired hyperlipidemia, and those either at significant risk of cardiovascular disease or those with established disease. We've also mentioned some of the most important drug classes, focusing as usual on their specific mechanisms, their effects, and the most important elements of their adverse profile. So I hope that you found this podcast useful and informative. As always, thanks for listening and see you soon.